Deborah Hartsfield is very familiar with ALS. She became interested in ALS while she was a research assistant at UC Berkeley. There, she was involved in exploring subjective, behavioral, and physiological reactions to laughing and crying on a pathological basis by those affected with ALS. She was also involved in additional studies related to dementia and ALS. With a degree in molecular biology and genetic counseling, she's currently a member of the Veterans Administration Genomic Medicine Service in Salt Lake City, Utah. Please join me in a warm welcome for Deb Hartsfield.
Thank you for that kind introduction. So I'm Deb Hartsfield. I'm one of 8 genetic counselors working for the VA. So we are a group of counselors all based in Salt Lake City, and we see veterans nationwide for a variety of indications. So a lot of family history of various cancers, neurological conditions, and actually we just got our first referral for family history of ALS. So haven't seen that too much starting off, but our service makes a goal to make genetic counseling available to every single veteran across the United States. And I think important for you and your families is also finding access to genetic counseling. And I know we talked a lot about some basic science in the morning, and I want to maybe recap that in a more simple fashion. But really, the focus of my talk is more on some of the psychosocial aspects of familial ALS. So decisions about genetic testing. What is genetic testing? Why are reasons that people choose to do it? Okay, so a really quick overview. I want to talk a bit about genetics and inheritance. And I know we've touched on that a lot in the morning in terms of research, but I really want to kind of give it on a basic level. What is genetic counseling? What does the process entail? What are genetic testing options? What are the protocols that you might see when you're going out to ask about testing? A real important question, I think, for families is the decision to even start genetic testing. How do we go about it? Testing somebody with ALS first, providing that information for the rest of the family. I think there isn't a lot of great data out there to say how many people that are at risk for ALS decide to get testing. I think the thought is that it's relatively low. So this, I know this was touched on in the morning, this is a very personal decision, whether somebody wants to be tested predictively, so before they would have the chance of having symptoms. A very personal decision, but as you all know, while it might be a personal decision, this is also going to affect the whole family, and there are a lot of reasons why people choose to do it and why people choose not to. And then I'm going to talk about some various considerations people make before testing, thinking about things like health insurance, life insurance, decisions to have kids, things like that. So this is a slide that's probably review for everybody here. We know that 90% of ALS is sporadic as opposed to the 10% that's familial. In sporadic ALS, men are more often affected, while in familial ALS, typically there's an even gender distribution, and that's because a vast majority of familial ALS is inherited in an autosomal dominant fashion, meaning both men and women can be affected. The average age of onset in familial ALS slightly lower than sporadic. So I only want to talk about real basic genetics because from a research perspective, we talk about the nitty-gritty. And I know for me, before I went back to school to become a genetic counselor, the last time I had genetics was freshman year undergrad, and I got a C+ in it. So I think it's always useful to really kind of dumb it down, for lack of a better word. So we know that there are probably 25,000 genes in every cell in our body, right? Those genes are responsible for our growth and development. The genes encode proteins, and those proteins control our growth and development. So, we have genes that control how tall we are, what color our hair is. There are genes that protect against cancer. There are also genes that determine how proteins fold, determine how cells interact with each other, determine how dendrites and axons in the neurons develop. So those are things that we know are at play with ALS. We also know that everybody inherits 2 copies of every gene. You're getting one from your mom, one from your dad. The genes are represented by those 4 DNA nucleotide codes, so CAGT. So that would be an example of a gene down there. we know that many things can kind of disrupt the way a gene works and disrupt the way a protein works. It can be as small as one letter being changed, and that makes the gene can't be read properly to make the protein. Some other things that we know is that if you take a huge chunk of a gene out, it makes it stop working correctly. If you insert more information, so like in the C9 expansion, there's too much material there. So there's a lot of different ways that genes can kind of go awry in the body. So here is not even a comprehensive list, but kind of a general breakdown of the genes that are associated with familial ALS. As you can see, a vast majority follow dominant inheritance, and I'm going to kind of talk through that in a minute. There's some much more rare forms that follow autosomal recessive and X-linked inheritance. And as we kind of learned this morning and discussed, only about, the 2/3 of families are going to have a known genetic cause. That leaves another third of families that are still looking for an answer, and I know that research is working towards that as much as possible to find an answer for everybody, because we know if we can't find the cause of ALS in your family, we can't offer testing to anybody in the family to use for decisions like having children, planning for the future, that type of thing. So here's just a little schematic about how autosomal dominant inheritance works. So basically, people that have autosomal dominant familial ALS, C9, SOD1, they have one normal copy of the gene and one abnormal copy of the gene. So that means when they have kids, they have a 50% chance of passing on the normal copy and a 50% chance of passing on the abnormal copy. So that 50-50 chance is for each individual child. Okay, so sometimes in families with SOD1 or C9 mutations, you might see all 5 children affected. And certainly statistically that's very different, but again, for each individual child, it's a 50-50 chance. And I want to touch upon penetrance, because that was an issue that was brought up this morning. Penetrance is kind of tricky. We know that for C9, it seems to be very highly penetrant at older ages. We also know SOD1 has reduced penetrance. Really what that means is that somebody can have the genetic mutation, so they can have that abnormal copy of the gene and never get the disease. So that's why sometimes in families with autosomal dominant inheritance, it might look like the disease is skipping a generation. What it means is that somebody who had the mutation never developed the disease. So, when you're filling in the family tree, that spot is blank. Another reason why it can look like ALS is skipping a generation is that people can die at younger ages from other causes. They never had the chance to develop it. The difficulty when you're thinking about genetic testing for genes that have reduced penetrance, we don't know who has the mutation. We can't predict who in a family is going to have a mutation and never develop disease. A lot of times in a lot of other hereditary conditions, reduced penetrance happens because the people that never develop disease either have other genes that are protecting them or environmental factors that somehow protected them from developing the disease. So when we talk about genetic testing for SOD1 and for C9, because they have reduced penetrance, being able to tell somebody you have the genetic mutation, A, isn't 100% going to be able to tell you, are you going to get ALS? And 2, it's not going to tell you exactly what it's going to look like. And that's because we know the disease can look much different in different family members. I've heard a few people mention, the way my disease has progressed is much different than my family members. So we know that, a main point I like to make is that genetic testing can certainly provide more information. It's not going to take away all of the uncertainty, okay? Because things are going to look different for each individual. A much more rare way to inherit familial ALS is autosomal recessive. Some other autosomal recessive inheritance pattern conditions you might have heard of are things like sickle cell anemia, cystic fibrosis. For this type of inheritance, both parents would need to be a carrier, meaning they carry one non-working copy of the gene. Being a carrier, you wouldn't have any symptoms. You wouldn't know you were a carrier. There would be no reason to be aware of that. But if both parents pass on the non-working gene, that means a child has no working copies of that specific gene. For the gene associated with autosomal recessive ALS, it's more juvenile onset. And so for that family history, typically you would see siblings who are affected the parents wouldn't be affected, and typically children of affected people would not be affected because the carrier rate for that gene is so low. Another very rare way to inherit familial ALS, and I know this might not be the case for anybody here, but just to kind of be complete, I want to explain that this is really a very heterogeneous disease. So a lot of genes, a lot of different ways for it to be passed on. In X-linked familial ALS, basically a mother has to have a non-working copy of the gene on her X chromosome. So men have an X and a Y chromosome, females have 2 X chromosomes. So that means a mother can pass on the abnormal X to a daughter or a son. A father who has the one non-working copy of the X can pass it on to his daughter, but could never pass it on to a son because he passes his Y chromosome on to his son. So you won't see any male-to-male transition. For the ubiquitin 2 gene, which is responsible for X-linked ALS, we know that it's reduced penetrance in women. So only 90% of women that have that mutation on their X chromosome are going to develop disease. So just to talk a bit about genetic counseling in general, what is the process? What does it look like? Genetic counselors are all master's trained healthcare professionals that are kind of trained in a balance of science and genetics and technology, along with the psychosocial piece, so the counseling aspects, the decision making. We do a lot of family history collection, so asking really specific questions, trying to outline when were diagnoses made, was somebody potentially misdiagnosed. You know, as we go further back up in pedigrees and family histories, it might not have been called ALS, so we try to kind of get to the bottom of that. Asking specific questions about dementia to try to get a sense of, is this maybe a family that looks more like C9, that does have frontotemporal dementia, versus SOD1, which is really more straight ALS. So we review those family histories, we conduct a risk assessment. What are the chances that you've inherited this mutation? Typically, for most families, it's going to be about 50%. How do we modify that risk? That may or may not include genetic testing. Again, a very personal decision. We discuss options. What's going to happen if you decide to get tested? What if you don't decide to get tested? And frankly, for the third of families out there that don't have a genetic test, how do we deal with that uncertainty, okay? And 10 years ago, when there weren't genetic tests available for, ALS or various other diseases, the counseling piece is the same. How do we deal with the uncertainty of developing this disease? And it's really only in the past 10 years that these tests have been available to give people this information. So that puts a lot of pressure on the families. Before, you didn't have this choice, right? Now you do have this choice, and the question is, do you really want to move forward with it? We help assist patients in decision-making. We also help identify other local, national resources that might be helpful. So I want to touch a little bit on the difference between a clinical diagnosis and a genetic diagnosis. We all know that diagnosing ALS can be challenging. There's a lot of differentials. There's a lag time between symptom onset and diagnosis. Once you have a familial mutation in the family, it might be a bit different. Once you know you're at risk, that lag time between symptom onset and diagnosis might be a little shorter. In terms of a clinical diagnosis, we know for sporadic ALS, genetic testing really isn't going to be that helpful. The detection rate is so low for people that have sporadic ALS, and so we're really working from a clinical diagnosis. The other aspect is getting a genetic confirmation of disease. So getting a genetic test result when you have ALS isn't going to change that diagnosis. There are some what we call phenotype-genotype correlations, so specific mutations might be able to give us a general idea of what the prognosis is. A general idea is FTD a possibility for you and your family, but it's not going to tell you how things are going to play out. It's not changing that diagnosis at all. It can help. Having a positive genetic test, knowing what gene, what mutation, might potentially make somebody eligible for a clinical trial. So that's one reason to consider it. One of the most important things about genetic testing is that can help guide other family members who might be interested in getting tested predictively. And I'm going to touch a bit on testing protocols in a minute. So we think of genetic testing in the genetic counseling world 2 different ways. Symptomatic testing, so once somebody has the disease, We're testing to see, can we find the gene responsible for the cause of the ALS in the family? The second type is predictive testing, and I'm going to talk a bit more about that. I prefer to call it predictive testing compared to pre-symptomatic because we know, again, some people with a genetic mutation are not going to develop disease. Again, a positive genetic test result does not diagnose ALS. It puts somebody in a higher risk category. So testing strategy. I think this is a real important thing to focus on here. So genetic testing is only going to be informative if somebody with ALS has been tested first, right? So if everybody in your family has passed away without having genetic testing and you go in, it's not particularly useful for you to get tested. So if your test comes back negative, that could very easily be a false negative. If we don't know what's causing ALS in your family, getting a negative test can provide false reassurance. So I really like to point out the benefit of DNA banking here. I know genetic testing, and especially for the C9 families where this is such a new development, this testing wasn't available before, right? And it is now. So if you are in a family where we don't know the genetic cause yet, I really do recommend the possibility of DNA banking. And I know it's possible that various research protocols and research studies that you might be involved with have that DNA. You can also do it kind of on a more clinical basis. So I know there's one company called Prevention Genetics. I think they're based out of Wisconsin. You can send DNA there, and I believe it's somewhere around maybe $150, and they store it for the lifetime. So, in those families without a genetic mutation, there will be a place for the children to go back in 5, 10 years when we know all the genes that cause familial ALS. They can go get that blood sample tested to provide the best and most accurate information for the rest of the family. When we're thinking about genetic testing, always important to think about the logistics. Do you get tested for a single gene, or do you get tested for the whole panel? Sometimes meeting with a genetic counselor can be helpful to evaluate that. We make those decisions based on the family history and often based on the most likely gene. I think a lot of people would use the strategy of testing SOD1 and C9 first because they're the most likely cause if it looks like it's autosomal dominant in the family. In general, I hear sometimes people say genetic testing is just a simple blood draw. And while that's true, the consequences are much bigger than that, right? So, yes, you would go and get a blood draw. That would get sent off to a lab. Typically, we would expect results in 4 to 6 weeks from after that blood draw. Some common concerns when we're thinking about genetic testing are things like the cost and insurance coverage. So going back to the strategy of do we do a single gene or do we do the full panel? SOD1 at some labs costs between $600 to $1,300 to just sequence that gene. C9 costs about $600, so a little bit lower. To get the full panel, and I think I heard somebody mention it this morning, to do the full panel of what's clinically available, it's $9,000. And when we're thinking about insurance companies, there are some insurance companies out there that unfortunately just have a blanket statement, no, we don't cover genetic testing, period. There are some insurance companies that will say we'll only cover genetic testing if it changes the medical management. So if you have to bear this cost on your own, it can be worth thinking about the strategies. How much money can I spend? Do I want to do the full panel? Do I want to do this individually? And on another note, sometimes if an insurance company, typically if they have a blanket statement they won't do genetic testing, you're not going to get very far with them. If they're saying, we won't do it unless it changes medical management and we know there's no treatment out there currently, to change the course, you can sometimes get providers and certainly genetic counselors to help you write a letter of medical necessity, for enrollment in clinical trials if you were to have a mutation in this gene, in order to help you make reproductive decisions. So if you can kind of make a cause for why this testing is going to change something for you, oftentimes we can at least work as hard as we can to make that happen. Other really common concerns with genetic testing, not just for ALS, but for any hereditary condition, is how is this going to affect my insurance coverage? So I don't have symptoms now. If I test positive, what does that mean? So a little background on what the federal government has done to kind of protect that. In 2008, the Genetic Information Non-Discrimination Act was passed. And really affords quite a few protections for genetic discrimination, but it doesn't protect against everything. So for people getting predictive genetic testing, this is going to protect you from being discriminated in terms of being able to get health insurance. Your premiums can't go up based on a positive result. Employment, employers can't make hiring, firing, promotion, or pay decisions based on a positive genetic test result. It is important to note that this federal law does not cover life insurance. It doesn't cover disability or long-term care. So from our perspective in genetic counseling, and we talk about a lot for Huntington's disease as well, when you're thinking about getting predictive testing, a lot of genetic counselors will strongly encourage you to get all of this in place before you get tested. And it's certainly possible that life and disability and long-term insurance might not ask those questions. I'm not an expert in that field, but if they do, you know, if for some reason they can have access to that genetic test, you want to have these things in place before you get your blood drawn. Testing protocols can really vary significantly between institutions. I think some centers kind of recommend going through a multi-step process. So some places you might meet first with a neurologist, and this is all for predictive testing, so people who are not currently affected. You might meet with a neurologist first, and then a psychologist, and then a genetic counselor. So it's kind of this multi-step process that I think some institutions think, you know, this is too restrictive. This is making somebody travel however many miles to come to this specialty center at an academic institution to get this test. And so that's why, you know, that protocol was specifically based on Huntington's disease. That's how the Centers of Excellence for Huntington's disease do their testing. They kind of make it this very long, drawn-out process. I know at the VA, sometimes we deal with this on a case-by-case basis, depending on the family history, depending on personal characteristics, depending on how far the patient is from accessing other services. So it really depends where you go as to how this testing is going to proceed. I do have to say, from my opinion, you know, I know that primary care doctors or general neurologists can certainly order genetic testing. I strongly discourage going down that route. I do think that it's beneficial to speak with a genetic counselor first for reasons that I'll kind of go into a little bit further, but we're really able to take the time to kind of address some long-term concerns versus just going in, having somebody that has the availability to order this test, they order it, and then you're done. So what happens at pre-test genetic counseling? We do some education. Frankly, people with familial ALS are more educated on the disease than a genetic counselor will ever be. And that's just the fact of it. But we do talk about genetics and inheritance. So kind of going over some of the slides I talked about before, oftentimes there can be misconceptions in families. For instance, my mother had ALS. I look exactly like her. Therefore, I think I'm at 90% risk to inherit this mutation. So we're able to kind of separate out the emotional and the scientific. What really is your risk? We talk about those health insurance and employment questions. We talk about GINA. We talk about what the possible test results are. So when you're coming in for predictive testing and we know the mutation in your family, really the possible test results are positive, meaning you inherited the mutation, or negative. In that case, a negative result is a true negative. That means you didn't inherit the mutation in your family. You are not at the significantly increased risk. We can never say you're at zero risk because we know there's sporadic ALS out there, but that puts you more in the 1 in 100,000 as opposed to the almost 100% that you're going to develop the disease. When it's a first person coming in for testing in a family, there are 3 possible results. Positive, meaning we found the cause for the person's ALS. Negative, meaning we tested however many genes, even if we tested all the genes that we know about, we didn't find the cause. So that just means we didn't find the cause in the 9 tests, the 9 genes that we have clinical tests available for. That might put you in the group of families that we don't know the gene yet, or we don't know how to find that mutation. The third possible result is called a variant of uncertain significance, and that's a much more tricky one. We call that a VUS, and it basically means the lab that did the testing found a change in the gene, and they just don't have enough information yet to determine, does this cause ALS, or is this just a normal change that's found in DNA between people? Typically, labs go to great lengths to try to reclassify those as positive or negative. A big thing that we focus on in pre-test counseling is talking about motivations. So some of the items on this list were taken specifically from a familial ALS cohort. And it's important to note that these reasons to get genetic testing are very similar to most hereditary or genetic conditions. So a lot of people choose to get testing because they are just really hoping they don't have the gene. They also want information to make decisions. When do we decide to have kids? How do we have kids? Is this the right career path for me? How do I spend the next 10 years of my life? Some people want extra time to adjust. They want to know, is this going to happen or is it not? A big reason for people to pursue predictive testing is to make reproductive decisions. Some people, we found, choose to test because they have such anxiety. They think that potentially every time they have a muscle twitch, they think that it's ALS and they can't really live with that anxiety anymore. And a lot of people choose to get predictive testing to help other family members. If I get tested and I'm negative, none of my kids are at risk, it's done. And so those are quite a few reasons why people choose to test, and I'm going to share some quotes from some people that I spoke with when I did a study that was really looking at people that are at risk for familial ALS, hadn't been tested when they chose to have kids. I was basically looking at what does the reproductive decision-making process look like in people at risk for ALS? How do they have this conversation with their partners? What do they decide? And through those discussions, it kind of came out that some people had chosen to get tested after that span of when reproductive decisions were made, and they kind of offered some good insight, so I'm going to share a few of those quotes. So one woman who ended up testing positive said, "I guess the bottom line for me was the hope of having a negative test outweighed the fear of a positive test. I just couldn't live my life anymore without knowing. I just hoped so much that it would be negative and that I could finally get out of that cloud. I hoped so much that it would be negative that I decided I had to do it because I couldn't work away the fear I had. Now I still have the fear that the disease is going to come, but that's the way I was living before. The hope of a negative test outweighed the fear of a positive." So another woman kind of discussed issues with the fact that she was already seeing symptoms in herself and she really couldn't deal with that level of anxiety anymore. She said, "The problem was not knowing, and knowing that you're at 50% risk is that every time you have a twitch, every time you wake up with a cold, every time your leg is numb, I mean literally you think about this once a week. I was constantly just living the whole day in, day out. Oh my God, I'm going to be gone in 4 months. And I had already set up all my trusts, my will, and stuff like that. But it just seemed like every week, every day, you were having some kind of twitch and you thought, oh, it's kicking in now. And so the best thing about being tested recently was when they said I wasn't positive, all of a sudden, all those thoughts have been out of my mind. You don't get a cold and think you're going to die in 4 months. And so that was a huge relief for me. Another woman had genetic testing and ended up testing negative, and a majority of her reason for testing was, A, she was seeing some symptoms in herself, but it was more to help other family members. So she said, I had a granddaughter, and she wanted to make sure that she didn't bring any kids into this world if she had the gene. When I got tested, it was for her, to find out if she was going to have kids. Later on, when she was talking about how she disclosed her negative test result, she said, I told my oldest son I tested negative. He said, I'm happy for you. I said, I'm happy for you. He said, why? I said, because if I don't have it, you don't have it, because it stopped with me. Once it stopped with me, it took all the pressure off all the family. So these are kind of some examples of the after the fact, motivations for why people choose genetic testing. On the other hand, there are some other just as valid reasons to choose not to know. I think in genetics, and certainly in genetic counseling, there's this idea that the more information's better. Knowing more is better. That's not the case for everybody. Some people, this information isn't going to be useful, or it's not the right time to find it out. So some reasons why people choose not to test is the acknowledgement that currently there's no prevention available. Why do I want this information if there's nothing I can do to stop it? Insurance discrimination. I think this is a common reason why people are concerned. I don't think there's enough data out there to say that insurance discrimination actually happens. And again, there are the federal protections around that, but I think people still have concerns about that. Another big reason why people decide not to get tested is because they don't want any guilt associated with the possibility of passing it on to the next generation. On a similar hand, they want to avoid guilt about potentially testing negative when other at-risk family members, sisters, brothers might test positive. Kind of on the flip side of people who already feel like they're seeing symptoms and want genetic testing to confirm or deny that, some people don't want to be tested because they don't want to know, they don't want to start worrying about disease onset. A lot of people want to maintain hope or frankly just want to prevent worry in the rest of the family. Again, these decisions aren't made in a bubble, right? This is affecting entire family structures. So one woman that I spoke with who ended up testing negative, she had really lived her entire life based on the fact that she thought she was going to get ALS. She never had children. She ended up marrying much later in life, but had really kind of planned to die young. So she talks about survivor's guilt, which is a relatively common phenomenon in genetic conditions. She said, I think I was disappointed that the test results came back and I was negative because I'm the only one that's kind of lived my life to die early, whereas my siblings have not done that. I know it's only 50% for each person separately, but when you look at 4 kids, you say, well, half of them are going to die young, and they all have kids. I think I was kind of disappointed it wasn't me, that I wasn't the chosen one, because I've kind of planned for it, and they're not planning for it. I guess I kind of have this guilt with it. I think this is an important quote to kind of exemplify the fact that a negative test result has implications as well. There are negative feelings associated with a negative result, and I think sometimes that can cause tension in a family. And there have been cases, I've talked to people that have gotten genetic testing and tested negative and then never told anybody else in the family. They felt too guilty about it, and kind of let other people in the family potentially assume that they were positive. So that's certainly something to consider when you're thinking about testing, that certainly a positive result has a lot of implications and is a very intense process. A negative result can have those kinds of consequences as well. So some questions to think about before you're considering predictive testing. And these are some things that hopefully a genetic counselor would ask you, or you should start thinking about before you go in through this process. What are you going to do with this result? What's your main motivation? Another good question is, why now? So why now and not 5 years ago? A lot of people typically think about getting tested maybe 5-10 years before the earliest age of onset in the family, or maybe at the same age that a parent was diagnosed. Some people choose to start thinking about this for family planning reasons. But kind of a good thing to sit with is why is this important to me now and it wasn't before? Is this still going to be important to me in 5 years? What does your family think? Again, when you're sitting in front of a genetic counselor or a neurologist, you're their patient. You're there to do what's best for them. Only you as a client, a patient, is going to know what's best for your family and how your family plays into things. So what does your family think? Who have you told in your family that you're considering this testing? A good question, do you believe that you inherited the gene? So again, going back to some people think, now I think I have a 95% risk of having inherited because there's this many people in the family, or I look like everybody that's affected. So what do you think the results are going to come back as? A very important question, what does your spouse or partner think about this testing? Hopefully they'd be aware. Or if you are not in a serious relationship yet, what is that going to look like for the future, right? Is getting a test result back going to prevent you from looking for a partner? How is this going to change your future? How is a positive result going to affect your relationships with your spouse, partner, family? How's it going to affect your decision to have children? How is that going to affect your career? If it's positive, are you going to quit and travel the world? Are you going to maybe make a different decision? For maybe younger people, are you going to decide, I'm not going to go through the 8 years of medical school, I'm going to choose something else? I mean, this can have large implications on how you choose to live your life. Financial planning, again, we heard some great information about that over lunch. These are important things to think about before you get the blood drawn. And importantly, how are you going to plan, how are you going to spend the next 10 to 20 years of your life? So these are just some general things we ask people to sit with before they actually make the decision. We also talk about coping mechanisms. So how have you dealt with challenges in the past? While maybe a different situation, we all use similar coping mechanisms kind of as we move on through our life. So what's worked for you in the past? Who are your support systems? Who's going to come with you to get the test result? Who are you going to tell that you're even getting tested? Are you going to tell your parents? Are you going to tell the parent that's living with ALS now? How are you going to tell your kids? What are you going to tell your kids? Are you feeling pressure from anybody else in the family? So as we saw before, there was one woman who got tested to help her grandkids and her son. I think it's important to sit back and think, is this something that I want for me? Am I doing it strictly for other people? Am I doing it for a partner that really wants to know, but I don't want to know? And what are the effects of the negative result going to be? We all think that that's going to be a really easy, a huge relief, which I think it certainly is for a lot of people, but what are the consequences of that negative result? And kind of on a more practical level, what are your plans for the day that we disclose the result? Typically, we suggest people have somewhat of a structured day, right? Go out to dinner with people, go along your usual routine. Some things we talk about after genetic counseling and after the test comes back, whether it's positive or negative, how is that impacting you? What resources do you need moving forward? How does this impact your family? What strategies can you use to talk with family members about this? And we often talk about reproductive options. So this is actually something that you would certainly talk about before you got tested, because there are quite a few options out there. But when people are getting genetic testing to decide about having kids, there's certainly a lot to think about. So we'd like to go through all of the various options. You can get prenatal diagnosis for a known familial mutation in the family. So that means a woman can get an amniocentesis, and they can test the fetus to see if the fetus has the familial mutation. The really hard part about kind of that technology, if you will, is that typically for things like ALS and Huntington's disease, if the fetus tests positive, it's really with the understanding that you're going to terminate the pregnancy. And that's because you're taking away that child's autonomy and their own ability to make the decision, do they want to know or not? And this is typical of a lot of adult onset disorders. In general, we don't recommend testing people under 18 years of age because these are all adult onset conditions, right? So 40s, 50s, 60s, you're leading a productive life up till then. We think that under the age of 18, you're not maybe really able to make those decisions. And certainly that's on a case-by-case basis. I mean, children are tested at 15 or 16, depending on their maturity level. So that's the one kind of reproductive option that's certainly quite controversial. Another option is called Pre-Implantation Genetic Diagnosis, or PGD. And that's a technology that's very similar to IVF. So they grow the embryos up, and then at about the 5 to 8 cell stage, they remove a cell. They test that cell. And they only implant the embryos that do not have the familial mutation. So you're able to implant an embryo, kind of ensuring that the baby is not going to inherit that mutation. There's 2 ways to do that. One, where a parent is already tested, the at-risk parent is already tested, and they know if they are positive or negative. Another way you can do it is called non-disclosing, meaning if the person at risk doesn't want to know, the lab can grow up the embryos and implant them without telling either part of the couple if the at-risk person is positive or negative. The one potential negative of that is that if there are no embryos that don't have the mutation, you kind of inadvertently end up disclosing that information. But another thing I really do need to mention when we're talking about PGD, it's typically not covered by insurance, and it's an additional $5,000 on top of IVF costs, which I think run around $15,000. So it's not a cheap proposition, but it's out there. Something that a lot of people consider is adoption. And when I did my study about reproductive decision-making in people at risk for familial ALS, most people considered every option, having their own kids, not having kids. Most people didn't even know about PGD when I talked about this, and adoption as well. One of the main concerns with that is, regardless if you're adopting and you're clearly reducing or stopping that risk of your child having the mutation or having familial ALS, is the same concern that your children might witness a parent die of the disorder. And so that was a concern in the people that we spoke to. Another technology that I think people don't talk about too much is the option of donor egg and donor sperm. So before I take some questions, some just really general resources. Again, I think it's very important to think about the implications of testing before you get it. Again, I think you can go to a primary care or a general neurologist and say, I want to know. I want to know, I want to know now. They will probably draw the blood and they will give you the results, but it's not going to be as similar as going to a genetic counselor. So the National Society of Genetic Counselors, there's a tab there that just says find a genetic counselor. You can search by zip code, you can also search by specialty. You could search under neurology as the specialty. Unfortunately, there aren't that many genetic counselors nationwide that specialize in neurology. That being said, we're a pretty small field, so if you contact somebody in your zip code that specializes in cancer or even pediatrics, that person should be able to see you. The counseling issues are similar among all hereditary conditions. The counseling techniques are similar. That genetic counselor should be able to find the scientific and genetic information, and if not, we really do kind of collaborate quite a bit. So if you find a generalist, that person can get in touch with a genetic counselor that specializes in neurology. Oops. GINA, so the law that I was talking about, there's a good kind of resource for what that covers, what it doesn't cover, and finally clinicaltrials.org, which I'm sure all of you are aware of. Right now there are some SOD1 trials enrolling. Hopefully there will be more coming up in the pipeline with C9 shortly. So. And I of course forgot to bring my card, but here's my contact information in case anybody has any questions. And I guess you know, I like to communicate that genetic counseling doesn't equal genetic testing. This isn't an easy decision. I think it's beneficial for people to go talk about the options with a genetic counselor. That doesn't mean you have to get your blood drawn that day. Just start the conversation, and we go from there. So.